Now we're going to talk about OMM for the lower extremity. This series is just going to be split into two videos. This first video we're going to go over the Spencer technique for the hip, the important muscle piriformis, the ligaments of the knee, and of course some counterstrain points. So we're going to start off with Spencer for the hip. So just like the Spencer technique for the shoulder, you're going to have multiple steps for the Spencer technique of the hip. So in order to memorize this, come up with another mnemonic that we can use. Felines eating catnip trip into everything around Austin. So remember, felines eating catnip trip into everything around Austin. So these letters represent the barriers that we are going to place the patient into for treatment. So the first one is flexion barrier, then you have extension, then you have compression with circumduction, then you have traction with circumduction, then you have internal rotation, external rotation, abduction, and then adduction. All of these motions you can do with the lower extremity flexed in order to get the motion correct. Another way to look at this is if you notice, every two barriers are opposite of one another. Flexion, extension, compression, traction, internal, external, abduct, adduct. So remember, felines eating catnip trip into everything around Austin. So now we're going to talk about the piriformis. This muscle comes up on just about every single OMM exam that I've ever taken, so we're going to spend some time to talk about it. So the piriformis origin is on the posterior side of the sacrum. The insertion is on the greater tubercle of the femur. So if we think about concepts in anatomy, what do you think the piriformis is going to do? It attaches on the sacrum, inserts at the greater trochanter. So if we think about the origin and insertion, we can get an idea of the motion that the piriformis does. When the muscle contracts, it brings both ends closer together, and to do that, the lower extremity must externally rotate. So the piriformis causes lower extremity external rotation. So function is lower extremity external rotation. So what about when it's dysfunctional? So think about this. When the piriformis is dysfunctional, it's going to be hypertonic. It's going to be contracted and stuck in that position. So it's going to keep both ends of the muscle closer together. What does that mean? It means that the leg is externally rotated. So when it's dysfunctional, you're going to see an external rotation of the lower extremity. Now here's a clinical correlate that always pops up on exams. You have to remember anatomically that the sciatic nerve comes out right below the piriformis. If the piriformis is dysfunctional and hypertonic, it can begin to compress the sciatic nerve. And when that happens, the patient will have lower extremity paresthesias, potentially some burning and shooting pain. So if you see something like that in the clinic or on an exam, they might be trying to tell you to take a look at the piriformis and see if it's dysfunctional. So to keep that in your head, I'm going to put sciatic nerve. So how are we going to treat this? There's a couple different ways to treat the piriformis, but the first one that we're going to go over is muscle energy. So thinking back to the beginning about how you do muscle energy, you put the muscle into the restrictive barrier where it cannot go. You have the patient flex into the freedom or where it can go. Do that multiple times, bring them back to neutral, rescreen. So the thing that you need to know for the piriformis is where is the restrictive barrier and what motion do they need to do to go into the freedom? Well, we already wrote it down. When it's dysfunctional, it can externally rotate. So what we're going to do to engage the barrier for muscle energy treatment is to internally rotate. So then what motion are we going to have the patient do isometrically in order to move into the freedom? We get them to do what the muscle can do, which is external rotation. So when treating with muscle energy, you always engage the restrictive barrier passively, and then you have the patient isometrically contract into the freedom. Once that the treatment's over, you're going to bring the patient back to neutral and rescreen. So we're going to leave piriformis behind and we're going to begin to talk about some of the ligaments of the knee. And to do that, we're going to draw a picture. So this is going to be your femur. And this is going to represent your tibia. Your fibula will be on this side to show you that this is lateral and this is medial. So there are four big structures that we need to talk about that are located in the knee. The first structures are on the medial side of the knee. And that's going to be your MCL, your medial collateral ligament, and your medial meniscus. So they're going to be located medial meniscus, MCL. Don't worry about getting into the nitty-gritty of what they attach to, where they are, what the function is. That's for your anatomy course. Just understand that they're located on the medial side of the knee and they help with knee stability. So next, the lateral side of the knee, we're going to see the lateral collateral ligament and the lateral meniscus. So it's just going to be on the opposite side. So you have the lateral collateral ligament and the lateral meniscus. Two more ligaments, and both are going to be noticed from the posterior side. You have the anterior collateral ligament, which attaches to the anterior side of the tibia and the posterior side of the femur. You also have the posterior collateral ligament. The posterior collateral ligament attaches to the posterior side of the tibia and the anterior side of the femur. The reasons that we're going over these ligaments is so that you can get an idea of some counter-strain treatments of these ligaments. So if the patient is having pain in their medial knee and you find a tender point there, you'll probably want to treat the MCL. Lateral side, you're going to think about the LCL. And if you're palpating on the posterior side of the knee, you're going to have to think about the ACL and the PCL. So we're going to go ahead and discuss what the counterstrain positions are for these ligaments and some other important muscles of the lower extremity. So counterstrain, you already know how to do this treatment. I think that we've beaten it to death. It's indirect. You bring the two ends of the muscle closer together. You fold and hold. It's that simple. So if you have a tender point located on the medial side of the knee, you need to think about the MCL and the medial meniscus. If you're going to bring the two ends of the MCL together, you're going to flex, adduct, and internally rotate. So you're going to flex the knee joint, you're going to adduct the tibia, so bring it closer to the body, which will then bring the tibia closer to the femur on the medial side, and then you will internally rotate the tibia. That's going to bring the two ends of the MCL closer together for your treatment position. We're going to compare that to the LCL and the lateral meniscus. They're located on the lateral side of the knee, so you're going to have to do the opposite that you would for the MCL. You're still going to flex, but you're going to abduct and externally rotate. So you're going to flex the knee joint, abduct the tibia away from the body, which will bring it closer to the femur on the lateral side, and then you're going to externally rotate the tibia to bring the two ends of the LCL closer together. So now we're going to compare those to the posterior tender points. On the posterior side, you'll have the ACL and the PCL. So for these two treatments, we're going to have to bring a friend to the party. We're going to have to use what we call the third osteopathic arm. Basically whatever you have laying around to help you with the treatment. So in this one, we're going to use a pillow as an example. So for the ACL, you need to bring this anterior attachment on the tibia and the posterior attachment on the femur closer together. And the way that you're going to do that is place a pillow on the posterior side of the femur and then posteriorly push the tibia. So imagine this, you have the patient laying on their back, you have a pillow underneath the femur, and you are pushing down on the tibia towards the table. That's going to push the tibia posteriorly, which is going to push this attachment closer to the attachment on the femur. The PCL treatment position is the opposite. So we're going to place the pillow under the tibia, and we are going to push posteriorly on the femur. This motion will then bring both ends of the PCL closer together. So the next two that we're going to compare, we're going to talk about the piriformis and the glutes. So we already talked about one way to treat the piriformis, which could be muscle energy. If you find a tender point and you want to treat it with counterstrain, you just have to put it into the position of ease, or what it can do, which we already discussed. The piriformis externally rotates. So you are going to externally rotate the lower extremity to do the counterstrain position. So for piriformis, your primary motion is going to be externally rotating. If you need to adjust slightly to make sure that you get below 3 on the pain scale, you can add slight abduction and slight flexion. What about the glutes? So the glutes are primarily extensors of the hip and the lower extremity. So if you're going to put it into the treatment position that it usually goes in when it's contracted, it's extension. So the treatment position is going to be extension. The rest of the position, if you need to adjust to make sure that you get below 3 on that pain scale, it's the exact same as the piriformis. Externally rotate and abduction. Primary motion, extension. So 2 more counterstrain points that we're going to go over. The first one is going to be the psoas muscle. And the second one is going to be iliacus. Now if you remember, we already went over the psoas muscle earlier in the video series. This point is located 2/3 of the distance between the ASIS and the umbilicus. It's primarily a hip flexor, and it causes side bending towards the dysfunctional side. So what do you think the treatment position is to bring both ends together? Flexion and side bending towards. So just as a reminder, the psoas counterstrain point is 2/3 the distance between the ASIS and the umbilicus. And the treatment position is going to be flexion, external rotation, and side bending towards the dysfunction. So we're going to compare that to iliacus. The tender point for iliacus is going to be located 1/3 the distance from the ASIS to the umbilicus. The motion of the iliacus is very similar to that of the psoas. So the treatment position is going to be very similar to the psoas as well. So for this, we're going to remember that it's 1/3 the distance from the ASIS to the umbilicus. And the treatment position is going to include flexion, external rotation, and instead of side bending towards, you're going to abduct the lower extremity from the side of dysfunction. So in this lecture we went over a lot. We went over the Spencer technique for the hip and the mnemonic felines eating catnip trip into everything around Austin. We went over the always important piriformis muscle, some of the major structures of the knee, and we related that to how to use it, counterstrain points. Talked about counterstrain points for piriformis, glutes, psoas, and iliacus. That's OMM for the lower extremity, part 1.